And good morning to all, and thanks for coming out so early this morning. And what I thought I'd do during the time we have together is really go over some of the potentially curative options for patients who fail primary radiation therapy. So those who have undergone radiation therapy with curative intent, and then for one reason or another have developed what appears to be a local recurrence only, and look through the various strategies. There's not a lot out there. Even though we're considered a center of salvage radical prostatectomy, we only do about 20 or 30 a year, a very small volume of patients. And I think there's a variety of reasons for that, which hopefully we'll get to in the presentation. Now, one of the issues with radiation therapy is, I think, a little bit of a misunderstanding by not only urologists, but also radiation oncologists about the implications of the definition of failure. So if one looks at the ASTRO criteria, whether it was the original 3 consecutive rises or the more contemporary Phoenix definition, which is nadir plus 2, one has to understand that that predicts basically a bad outcome: death, metastatic disease, or development of a PSA over 100 in the patient's lifetime. So if one waits until a patient becomes nadir plus 2, you really have waited too long to evaluate that patient for a true local recurrence only. And as you'll see, most of the series that we look at, whether it be a surgical series, a cryotherapy series, or even now the salvage brachytherapy series, the men in those series have median PSAs that are much higher than nadir plus 2. So they've really already crossed the threshold of being incredibly high risk for distant disease, even though we call them local failures. As we know, there are a variety of factors after radiation therapy that can contribute to PSA changes. Men are often treated with hormonal therapy, so you have to wait until the hormonal therapy is completed, their testosterone recovers, their PSA starts to rise, and then monitoring that until it hopefully stabilizes. PSA bounce or radiation prostatitis, whatever you want to call that as. So it's very difficult to interpret what's going on in a man that has had radiation therapy, and because of some of the morbidities of radical or salvage radical prostatectomy, I think there has been a reluctance to even look for local recurrences. We might as well tell the patient that they're doing well because we really don't have anything meaningful to offer them. And so I think there's been this nihilistic view of if a patient fails local radiation therapy, they have systemic disease. Now, the key aspect of evaluating a man with a rising PSA after radiation therapy is really trying to determine local versus systemic disease, and we don't do a very good job of that, and it's primarily because we don't have great imaging studies. And this is where I think basic science will hopefully solve some of these issues, not only in this area, but also for regular patients who have not undergone prior therapy. We're left with things like what's the PSA value, looking at the biopsy features, and about the only thing that stands out is a very short PSA doubling time, less than 3 months, but that occurs in the vast minority of patients. It's no more than 10 or 15% of patients will have a really rapidly rising PSA, so you're left with 90% of the patients. Most of them, if not all of them, will have negative metastatic workups with whatever scans you want to use. And so you're left with, in many ways, having a clinical intuition or best guess that the patient has local versus systemic disease. So in terms of managing a patient, if you believe they do have a local recurrence, certainly one option is to observe them with either delayed hormonal therapy or early hormonal therapy. Certainly that works well in selected men, older men, those with comorbidities, someone who doesn't have a realistic life expectancy. But many of the men still have longevity. And with the improvements in cardiovascular health care and the like, life expectancy is prolonging. So many of these men do have a reasonable life expectancy. And if they are considered to have local recurrence only, there are a variety of salvage treatment options available to them, from radical prostatectomy to cryotherapy, HIFU. There's a number of different ways. And I think one of the things that I hope will contribute to at least looking for local failures earlier is that now the radiation oncologists have something to offer the patient, which is salvage brachy. And I think this reluctance to looking for local recurrences when a man just has a slowly rising PSA before it reaches nadir +2, perhaps the trigger to do a biopsy to look for persistent disease in the prostate will be lowered so that patients can be found earlier when they are truly more curable. So when one is faced with a patient, excuse me, they've been diagnosed with a local recurrence of prostate cancer after radiation treatment, you really have to do a good evaluation of the patient in terms of what did they have originally. So if they had a tumor that was a bulky T3 cancer, multiple positive biopsies that then went on to hormonal downstaging and radiation treatment with long-term hormonal therapy, and they ultimately fail, they're probably not the best patient for salvage anything locally. But if the patient had a type of cancer that you would have said, yeah, that man was a good candidate for a radical prostatectomy at the get-go, that's probably still a good candidate for a radical prostatectomy now, as long as their features are appropriate. The second issue is the patient does have to be in good health. So the same rules, we use a 10-year life expectancy, fudge that a little bit. But they basically have to be a good surgical candidate. And lastly, they can't have a lot of significant side effects from their radiation treatment. Those men with severe bowel issues typically don't tolerate other treatments to their pelvis very well. So salvage radical prostatectomy has been used for many, many years, and in many ways appropriately, it hasn't gained widespread use because there is a significant risk of perioperative morbidity. And also, we didn't know how to select patients. Early in the series, and this, as you'll see, goes back to the early 80s, we didn't know the role of PSA. And so there were patients in this series that had very high PSA values, patients that had locally advanced disease that really shouldn't have undergone a salvage procedure, and they all failed early. So there were questions about whether or not salvage prostatectomy could even cure patients. But what we did is basically, and this is getting a bit dated, we should update this, but we looked at, and you'll see the time frame, it's 1984 to 2003, so it took about 20 years to accumulate 100 patients. So salvage radical prostatectomy was not something that was done every day of the week. Now, the reason we divided the groups between 92 and 93 is because most of the patients before 1992 had undergone some type of open pelvic procedure. Many of those were the old open gold seed implants, where the prostate, actually the endopelvic fascia was incised, the prostate was mobilized, and you placed seeds in the prostate through a infraumbilical incision, and/or the patient had a pelvic lymph node dissection. So these are men that had had prior pelvic surgery, and what we learned in retrospect and why we divided the data at that point was that those men had far more complications and were far more tedious operations and had far worse outcomes. But as you can see, as time went on, and this was patient selection and perhaps surgeon experience, at least the time in the operating room was less. And then ultimately, you'll see early in the series, because many of these had had those prior pelvic procedures, there were a lot of combined operations, having to go perineally as well as retropubically, whereas nowadays, and certainly in the last 10 years, we've basically done the standard radical prostatectomy that we're all familiar with, at least standard open radical prostatectomy that we're familiar with. And again, these can be fairly bloody operations. Sometimes the prostate is basically adhered to the underside of the symphysis, so you can get into the dorsal venous complex early and often. But typically the blood loss is about average for what we saw during the open surgeries back then. Length of stay is decreased, and even though the length of stay has declined to about 2 or 3 days, the readmission rates for problems with earlier discharge really haven't increased much. So in terms of complications, we have improved. I mean, the number of rectal injuries these days is quite low. Occasionally we'll get into the rectum, but typically those can be repaired in the setting. You don't have to do colostomies and the like. But fortunately, getting into the rectum has been reduced. The number of ureteral injuries has been about the same over time. And many of these patients had already had a node dissection. So there were few patients in this group who had actually undergone pelvic lymph node sections at the time of their salvage operation. So we did have one obturator nerve injury, but nothing dramatic pops out from at least those intraoperative complications. And again, in the immediate postoperative period, again, very reasonable complication rates as we've gained experience over time and the surgical techniques have improved. The one area where we still have an issue is with the development of anastomotic strictures. And it's, over time, that has not improved. And I'll tell patients it's about a 25 to 30% risk. And this is an open series. There's some more recent data from some of the laparoscopic and now robotic-assisted laparoscopic procedures that have suggested that bladder neck contracture rates are actually lower, even in the salvage setting. So we'll have to see whether or not that holds true with more experience and larger series. But hopefully, by being able to do perhaps a more watertight anastomosis, a little bit better anatomical reapposition, that anastomotic stricture rate will be reduced further.
Do you routinely do a lymphadenectomy?
Nowadays, yes. And it basically has the limits of what Studer would do, had described. I'll get to some of the histology of that in a moment. Continence is also an issue, especially in those men who develop an anastomotic stricture, because those scars tend to be very dense. This is not something that you will just put a little balloon dilator in and stretch up once and they'll be fine. These are dense contractures. They typically have to undergo transurethral resection many times more than once, and those patients are at significant risk for incontinence. But the overall rates and this is a pad-free rate basically, it's about 2/3 of the patients. So what I tell a patient is about 50% of the time you'll end up dry, 50% of the time you'll end up wearing 1 or 2 pads a day. Sorry, 25% of the time you'll end up wearing 1 or 2 pads a day, and 25% of the time you're going to need a sphincter. And that's the reality, at least in open salvage radical prostatectomy. The bladder neck contracture rate and the incontinence rates are still quite high. From a histologic, pathologic standpoint, you can see that early on in our early part of the series, we did not do a very good job of selecting patients. Only 17% actually had organ-confined disease. The node positivity rate here is somewhat artificially low because we didn't do many node dissections in this time frame because of the reasons I mentioned earlier. In our more recent series, it's about 14% had positive nodes, but there were still some patients with very advanced disease, 27% with seminal vesicle invasion, and only about half of the patients had organ-confined disease. So we were getting better at patient selection, but still these patients were diagnosed late in their course, and many still had features of advanced disease. Fortunately, our positive margin rate, as we became more comfortable going wider in these patients, has declined to about 10%. In terms of progression-free probability, and this is just defined as a PSA that's greater than 0.1 and reproduced, it's about 50% at 10 years. So right there is about 50%, and that's 10 years. So the biochemical recurrence-free rates, about half the patients will remain free of biochemical recurrence. And you can predict that based on their initial PSA, and this all makes sense. But those men that had a PSA of less than 4 do much better. And the lower you go, the better you do. And so that's why this nadir +2 definition, if you keep waiting for their PSA and waiting for their PSA, if you can diagnose them earlier in the course, they tend to do much better. But we saw a difference between the PSAs just based on 4. Those with lower Gleason scores, of course, and you can do Gleason scoring in the salvage setting. If your pathologist is comfortable with that, most of our patients will get Gleason scored despite the prior treatment effects. And those with Gleason score of 7 or less do much better than those with Gleason scores of 8 to 10. And the good news is that oncologically it is a very good operation. And while there are aspects of biochemical recurrence, from the standpoint of local control, you rarely have a symptomatic local recurrence. So one of our fellows went back and updated our series when we were at about 125 patients. And while there were a number of biochemical recurrences, only one patient actually had a local recurrence that was symptomatic and needed to be treated. That patient had a TURP when he had hormone refractory metastatic disease about 6 months before he passed away. So at least from a local control standpoint, salvage radical prostatectomy tends to be a very good treatment option. None of these patients required stenting or nephrostomy tubes or had upper tract issues that is common in patients who have not had their primary disease controlled and become advanced patients. If one looks at death rates, actually the chances of dying after salvage radical prostatectomy is quite low. It's only about 20% at 10 years, and it's very similar to death from other causes. So at least from a more solid endpoint than biochemical recurrence, these patients tend to have a protracted natural history of disease. One can argue whether surgery interrupted that, but it certainly seems to have at least some beneficial effect in some of the patients that we treat. Recently, we combined our data with a number of different centers. About 400 patients from around the world underwent salvage surgery. Again, the median PSA in this group was still 4.5, which is realistically quite high and leads to unfavorable histology. But if you look at the overall rates, at 10 years, the freedom from biochemical recurrence was about 1/3 of the patients. So at least from a BCR standpoint, it's not fabulous, but about 3/4 of the patients were free of metastasis, and a little over 80% were free of cancer-specific or had cancer-specific survival. So at least from a hard endpoint rather than just a biochemical endpoint, these patients seem to be doing well. We did not have local recurrence evaluated in this series. So what we have learned over the years is that certainly this is an operation that can be performed safely. The numbers of complications, having to do total pelvic exents, getting fistulas, those days of really poor quality results for our patients don't happen anymore. It is a much more tedious operation. The normal planes of dissection are obliterated. So it's not the first surgery you want to do when you get your license, but it is a very doable operation. Certainly we've gotten better. They've had fewer pelvic procedures, and radiation has gotten better. The targeting for radiation therapy is superior, and all of those, I think, have combined to make this a safer operation. Long-term progression-free probability, at least in terms of metastatic progression and death from prostate cancer, are quite reasonable. We still suffer from identifying patients too late. And I think this reluctance to try to find local recurrence, hopefully, will be biopsying patients and looking for these recurrences earlier when patients truly can be cured. In terms of what I would call the thermal therapy, so either cryotherapy or HIFU, these are very appealing alternatives to patients who have failed locally after radiation therapy. After all, these patients selected radiation at the outset, so they were not inclined to have a surgical procedure when they were initially diagnosed, and many of them are not inclined to undergo what is now a bigger operation with a worse side effect profile than standard radical prostatectomy. Many of the cryotherapy and HIFU procedures are done as an outpatient, and the early treatment pathway for the patient is much easier than undergoing a major pelvic surgery like salvage radical prostatectomy. The problem is the potential that it just doesn't work well. And that's because of the nature of how the techniques are delivered in order to have very low side effect profiles. So we'll get into this shortly, but if you think about HIFU and how it's delivered and cryotherapy, how it's delivered, they're in many ways not treating the entire prostate. So with cryotherapy, there's the urethral warmer, so the central portion of the prostate periurethral is not treated. And with HIFU, typically the apex is spared to try to preserve continence. And so if there's cancer in those areas, there's the potential for the patient to fail. So we basically went back and looked at our our more contemporary salvage radical prostatectomy whole mounts to see, well, what is the likelihood that a patient will have cancer in those areas that may be undertreated by these thermal therapies. And Bill Wang is one of our former fellows who did this project. And basically, he looked at, ends up being 46 consecutive patients, and basically looked at the pictures. And this is not cherry-picked. This is the typical map we see when we do a salvage radical prostatectomy. Relatively large volume of tumor, and to our surprise, many of these actually encroached upon the urethra. Many of these had a large anterior component, and many of these had a significant apical component. So if you look at, and you can avoid all of the numbers, the punchline is right here, is that basically 2/3 of these cancers were within 5 millimeters of the urethra, which is in the area that is potentially undertreated when one does salvage cryotherapy and one does salvage HIFU. So one has to be concerned about these areas, not only in doing the treatment, but if you're monitoring the treatment, you don't want to biopsy where you freeze or heat very well. You want to biopsy in the apex and periurethral. That's where you're going to have your recurrences after the salvage thermal therapy. So that's why we have been reluctant to adopt these technologies in treating our salvage patients. There's an institution down the street that does a lot of salvage cryotherapies, and we just let them, if the patients want to have that technology, they just go down there. And so the punchline again from this study, 2/3 of the patients had cancer in their periurethral area, 2/3 of the patients had cancer in their apex. Again, concerning for patients who are undergoing salvage treatments. So from the standpoint of salvage cryotherapy, certainly this has had some technological improvements over the last couple of decades. When this was originally introduced for prostates, there's some folks with gray hairs in the audience, it was a very cumbersome technique. The probes were quite large, it was liquid nitrogen, and basically we had very poor ultrasound imaging that would allow us to guide the freeze. And we realistically picked the wrong patients. We picked those with big clinical T3 tumors. So there were a lot of complications, a significant amount of incontinence, a significant amount of fistulas between the rectum and the urethra bladder, et cetera. So it was really fell out of favor. But to their tribute, the engineers kept at it, and the approaches today are actually very slick. It's a very small needle, very similar to what we would do with brachytherapy, a brachy template. You can insert the needles, you use liquid or argon gas, and the techniques are quite nice. There is the urethral warmer, which, as I mentioned, is a concern, but it can be done safely, and the patients, in the short term anyway, from a recovery standpoint, do very, very well. This is one of the larger series that has been published with salvage cryoablation, a little less than 200 patients, about the same time frame as our more contemporary group that we treated with salvage radical prostatectomy. The majority of patients do undergo a period of hormonal therapy, so again, that will impact PSA recurrence rates, which they report. Follow-up was relatively short, but 3 years is reasonable. And the one aspect of cryoablation is they really haven't come up with a meaningful definition of what is biochemical failure. They basically adopted what is used in the radiation world. And whether that's appropriate for a strategy that is supposed to be completely ablative is probably not a great definition. But be that as it may, they adopted the Phoenix definition. A little bit difficult to see, but the boxes perhaps highlight this best. If you look at their outcomes in terms of biochemical failure, so these are Nader +2 rates. So again, not just a detectable PSA, but something that will predict bone scans being positive, death from prostate cancer, et cetera. Their 5-year biochemical recurrence-free rates, even in the most favorable group, those with a PSA of less than 4, is only 56%. Now it's not fair, but we always do it to compare series that are different. But in our group with similar PSA findings, 5 and 10-year rates were 82 and 69%. So again, suggesting that at least oncologically, there are a number of PSA recurrences in terms of those patients undergoing salvage cryotherapy. The treatment is safe, but it's not without its own risks. So there are patients that do develop incontinence. It's certainly not to the level or to the degree that we see with salvage radical prostatectomy, but it's also not everyone ends up continent after the procedure. About a 3 to 5% severe incontinence rate. There's still stricture rates, and then you can see the other complications. This perineal pain after treatment actually can be quite significant, and I'm not sure if it's a combination of the radiation therapy and then having had the cryo on top of that, but it seems to be much higher than with just cryotherapy at the get-go. So I think it's a combination of two inflammatory inducing treatments resulting in significant perineal pain for some of these men. Lou Pisters and the group at MD Anderson, where they did a lot of salvage cryotherapy, got together with the folks at Mayo. And again, it's different series, different hospitals, but they basically looked at their outcomes with salvage therapy. Those at MD Anderson were primarily treated with salvage cryotherapy. Those at the Mayo were treated with salvage radical prostatectomy, and they tried to match them up as best they could in terms of eligibility, which are all listed here. So the typical patient group, a little higher PSA than we'd like to see, but PSAs under 10, etc. And what they did is they basically just looked at outcomes. And they had good follow-up, and basically, as we'll see, it's probably easier to see on the curves. If you just looked at a detectable PSA, which they defined as greater than 0.4, the curves are obviously widely separate, as are the curves for overall survival. And what they concluded from this is that if you had a younger patient, really meaning someone with a longer life expectancy, that salvage cryotherapy was probably not the route that you would want to go. You'd rather do a more definitive oncologic procedure on those patients, whereas older men, men that did not have longevity, I think they were kind of throwing salvage cryo a bone in this paper, but they basically said for those men that salvage cryotherapy was perhaps an option, but they may not need any treatment either. The other treatment is HIFU. There's not much in the literature about HIFU. Again, outpatient treatment, very appealing to the patient. You don't even get poked with a needle other than your IV site. So you can really sell this to a patient as a minimally invasive option, but again, it suffers from the potential for under-treating areas of the prostate where there is a significant likelihood of having cancer. Again, a very small series out of Europe, only 31 patients with very short follow-up. And side effects are not insignificant. Even in non-radiated patients, HIFU can have some significant problems with strictures and sloughing, and as you can see, that's also apparent in the group that has undergone salvage HIFU. About a third of the patients requiring intervention just for stricture disease, and while the early oncologic outcomes are acceptable, again, that was with a median follow-up of only 7 months. And the newer treatment, which again, not much experience with, is using salvage brachytherapy or salvage high-dose radiation therapy. And the concept is that the radiation failed because there was either too low of a dose or it was delivered inappropriately. So that radiation is still a curative therapy in these patients, and it probably would have been originally if it had been delivered appropriately. So in many ways, ignoring the concept that there may just be some radiation-resistant prostate cancers. Again, short-term follow-up in small numbers of patients. It can be done safely. Again, failure is defined by that Phoenix definition in this series. But basically, not unreasonable biochemical recurrence-free rates, but again, 10 years, 50% using a Phoenix definition. And as has been shown in all of the series looking at salvage therapy, PSA is what predicts outcome. The lower the PSA one has, the better one is likely to do in terms of oncologic outcomes. It typically is well done. Grade 3 toxicities are rare, at least in this series, but there is the potential certainly for significant rectal toxicity in certain patients. So you have to be careful. You just can't inadvertently just throw some seeds into the prostate and hope it works. This is another series which has far inferior results. Again, longer follow-up than that initial series. So again, concerns about many of these patients will receive hormonal therapy, so that with longer follow-up, perhaps the PSA recurrence rates, even using a Phoenix definition, will start to fall off. So in summary, somewhat biasly, I think the data that we have today on salvage therapies for local recurrence after radiation therapy are really incomplete. There aren't many large series where we can make definitive statements, but I think the data to date would suggest that from a purely just oncologic outcome, that salvage radical prostatectomy provides the best long-term oncologic benefit to the patient. Unfortunately, that procedure is also associated with the highest risks, primarily with bladder neck contractures and with incontinence. It's yet to be determined whether using minimally invasive approaches, robotic-assisted laparoscopic approaches might improve the bladder neck contracture rate. We'll see. We've done, I think, somewhere between 15 and 20 lap and or robotic salvages, and I think we have one bladder neck contractor. So incontinence was still an issue in those groups, even without the bladder neck contractures. But we'll see in the longer term as we get more experience whether that holds true. Certainly HIFU, salvage brachy, salvage cryotherapy are options. There are concerns about their long-term oncologic efficacy, but they truly are appealing to the patient because of their minimally invasive nature, outpatient techniques, etc. But there is concern that in the long term, especially if it's a younger patient who is undergoing a salvage treatment, that these just don't provide them with the long-term results that they need. And with that, I'll stop, and I think we've left plenty of time for questions and getting to work early today.